Welcome back. Greetings, everyone. Good morning from Indonesia, and hello, welcome back to 19th Indoanesthesia 2022. So this is our final day. I hope everyone's still excited. Yay! So today we're going to have a lineup of wonderful speakers with very interesting topics. Untuk teman-teman yang di Indonesia, selamat datang kembali di acara Indonesia ke-19 tahun 2022. Untuk teman-teman di Indonesia, jangan lupa ini hari terakhir untuk memenangkan 3 door prize untuk 3 peserta yang beruntung. Jadi aktif bertanya, nanti kita akan pilih 3 orang yang mengikuti acara dari awal sampai akhir. Okay, so we're going to proceed with the first session. The first session is something very interesting. We're going to talk about airway management. And we will have 3 prominent speakers in this field. The first one is Dr. Joseph Tan from Singapore. Hi. And the second one is Dr. Akihiro Suzuki from Japan. And last but not least, we will have Professor Andrei Van Zunder from Australia. As for this session, it will be led by Dr. Andrei from Indonesia. And also, I would like to thank Advanced Medicare Corporate Indonesia for sponsoring this session. Please, Dr. Andrei.
Thank you, Dr. Krisha. Thank you to Advanced Medical Corporate for sponsoring this session. We are going to talk a lot about airway management this morning. For the first session, we have Dr. Joseph Tan, who is working at KK Women and Children Hospital. She is the pediatric anesthesiologist. She's going to present about the neonatal airway, about the challenges and opportunities. So we have a lot of time managing the difficult airway in neonatal patients. Speakers to save some time. We have a lot of time. We have about 30 minutes for each speakers. To save some time, we would like to ask Dr. Joseph Tan to start
friends and
her
colleagues from
presentation.
Indonesia.
Please, Dr.
Thank you for inviting me to be a part of Good morning, friends and colleagues from Indonesia. Thank you for inviting me to be a part of Anesthesia 2022. My topic this morning is the neonatal airway, challenges and opportunities. Many anesthesiologists, despite touted as airway experts, still consider pediatric airway, and more so, neonatal airway management intimidating and daunting, from fear of failing to secure the airway, especially when called upon by the neonatologist for a failed intubation in the neonatal ICU or delivery suite. And there is good reason to be so. Publications have consistently shown that infants and neonates are at increased risk of critical airway events. Bradycardia, fluctuations in blood pressure, and severe desaturation commonly occur during neonatal intubation. But do not let fear stop you from delivering due care to a child. It is important to simply keep calm, take control by going back to the basics. Safe and effective airway management of neonates requires an understanding of the neonatal airway anatomy, respiratory physiology, and their clinical implications. What features define the neonatal airway and set them apart from the older child and adult? The neonatal upper airway is prone to obstruction. They are preferential nasal breathers, but can breathe through the mouth, though may be insufficient when nasal passages are occluded. The tongue is large relative to the mouth, filling the oropharynx, and can easily obstruct the larynx when the baby loses consciousness. The larynx lies higher relative to the cervical vertebrae, near C2, C3, versus adult location at C4, C5. With the larynx higher, the tongue and soft tissues can easily obstruct the larynx. The neonatal larynx also has an anterior laryngeal tilt, such that its axis is directed into the base of the tongue, and the base of the tongue in the neonate occupies more of the posterior hypopharynx. Therefore, lifting the tongue with jaw thrust and or placement of an oral airway is essential to minimize upper airway obstruction in a sedated or obtunded neonate. epiglottis is longer, narrower, larger, and less flexible, often described as omega-shaped. This shape, combined with the short, airy epiglottic folds, may lead to inspiratory collapse and obstruction of the upper airway. Laryngeal and tracheal cartilage is soft and easily compressed. Excessive flexion or extension of the neck, as well as external pressure on the larynx, example by our adult-sized fingers on the neck during mask ventilation, can easily obstruct the airway. Laryngeal and tracheal diameter is narrow, easily blocked by secretions, and even minimal edema can cause significant obstruction with notable increase in resistance and work of breathing. The neonatal trachea is also short. Accidental extubation and main stem intubation can occur easily with head position changes. The neonatal occiput is large and round compared with the flatter adult skull. As a result, when the neonate is supine, the head is pushed into flexion, often resulting in upper airway obstruction, difficulty with mask ventilation, and a poor direct laryngoscopic view if the head is not repositioned and stabilized. To optimize the airway, the shoulders should be raised with a posterior support and the head shifted to a neutral or slightly extended position. However, do take note that overextension of the skull on the neck may result in obstruction as the airway is stretched and then narrowed. Full-term neonates are born with 20 million to 50 million alveoli, about 10% of the 200 million to 500 million found in the adult, giving them about 26 times less surface area for gas exchange. With smaller lung volumes, higher metabolic rate at least twice that of the adult, a mechanically less efficient chest wall limiting the ability for lung expansion, and a tendency towards breath holding, laryngospasm, and central apnea in response to airway stimulation, neonates are at the greatest risk of hypoxia compared to the older child and adult. Hypoxia, when not promptly rescued with oxygen and ventilation, will quickly lead to bradycardia and cardiac arrest. Useful airway maneuvers in the obtunded neonate includes continuous positive airway pressures and PEEP to improve and maintain functional residual capacity. With these considerations in mind, the neonatal airway is generally not so difficult to manage. However, not all neonates are the same. Alveoli form at 17 to 28 weeks of gestational age. The unborn baby starts to make surfactant at about 26 weeks of pregnancy. If born before 32 to 34 weeks, surfactant production is incomplete, predisposing the child to respiratory distress syndrome. Thus, premature newborns are not only compromised with incomplete development of alveoli required for gas exchange, they are also lacking in surfactant, which keeps the alveoli from collapsing with each breath, resulting in extra effort to reinflate the collapsed airways. Given the increased vulnerability, premature and very low birth weight neonates deserve special attention. It is no surprise that premature neonates become desaturated more rapidly than older infants and children when apneic. Dr. Taylor Sawyer from the University of Washington in Seattle, in his retrospective cohort study using prospectively collected data from the National Emergency Airway Registry for Neonates database, reported difficult tracheal intubations in the neonatal ICU to be more common in small preterm neonates, in particular, those less than 32 weeks corrected gestation and or those less than 1,500 grams body weight. Failed tracheal intubations were frequently associated with severe oxygen desaturation and linked to intraventricular hemorrhage and neurodevelopmental impairment in premature infants. How can we make intubation safer in this vulnerable population? Accurately predicting which neonate will be difficult to intubate may improve intubation safety in neonates. These are some examples of syndromes that are infamously linked to difficult mask ventilation and/or difficult laryngoscopy and intubation. Bedside difficult airway screening tests are commonly used in adults, but because they were not developed specifically for children, these tests should be used with caution in the neonatal population, particularly in the very preterm babies. However, known prior history of difficult airway, small mouth, limited neck movements, micro or retronadia remain useful predictors. Unexpected difficult intubation is reported to occur more frequently in neonates and infants than in older children. Thus, when managing airway in young children, it is prudent to remain vigilant despite absence of difficult airway predictors. Difficult airway algorithms have long provided us with useful working frameworks for systematic and appropriate decision-making when managing a difficult airway. The updated 2022 report of the ASA Practice Guidelines for Management of the Difficult Airway for Adults emphasize awake intubation when a significant risk of a difficult airway exists, or consider awakening the patient if the difficult airway does not need to be secured emergently. Other highlights include to optimize oxygenation throughout, with low or high flow nasal cannula, or non-invasive ventilation during pre-oxygenation, with head in the elevated position. There are also repeated reminders to limit intubation attempts, be mindful of the passage of time, call for help and expert help early for possible invasive access. The basic principles in the difficult airway algorithm remain similar for children, except that awake intubation is generally not possible in young children. Difficult airway guidelines specific for neonates are also available. They exhibit similar principles, stressing the importance of preparation and good basic airway management by ensuring appropriately sized equipment and proper airway maneuvers are applied. Maintain oxygenation and limit attempts to 2 or less. Advocate for quick transition to indirect intubation techniques when direct laryngoscopy fails, and an early trigger for the airway response team to respond when difficult airway is experienced. Based on the risk of difficult tracheal intubations in small preterm neonates and the potential for adverse events, it seems wise to have more experienced clinicians intubate these young infants. Consideration should also be given to using video laryngoscopy and pre-medication with paralysis, as these have been shown to be linked to greater first attempt success and fewer adverse events. The neonatal guidelines similarly stress the importance that time is of essence. Call for expert help early. This statement from the British Association of Perinatal Medicine sends an important message that we should not be bound strictly by algorithms and numbers. It reminds us that there is really no absolute to when a difficult airway situation should be declared. If an experienced clinician judges the airway to be difficult, he or she can declare a difficult airway situation even without pursuing 2 intubation attempts. It is no surprise that difficult airway management strategies in adults and older children can be applied to neonates and infants, but there are several challenges unique to this population. Young children display features of physiologic difficult airways. Neonates and preterm neonates, given their reduced functional residual capacity and propensity to alveolar collapse, are at increased risk of oxygen desaturation, which often forces the clinician to abandon intubation attempts despite decent glottic views and eventually to multiple intubation attempts with increased risk of complications. Physiological instability associated with intubation is the most common reason cited for failed intubation in neonates. In older children and adults, difficult airway algorithms recommend routine pre-oxygenation and apneic oxygenation, using 100% oxygen to delay the onset of hypoxemia during attempts of tracheal intubation. By incorporating this practice as standard of care for tracheal intubation in neonates, we could increase apneic times, reduce need for multiple attempts to intubate the trachea, minimize complications associated with repeated attempts. However, these concepts of pre-oxygenation and apneic oxygenation are not universally adopted for the neonatal population due to concerns regarding potential adverse effects of hyperoxia and oxidative stress-related morbidities like chronic lung disease and retinopathy of prematurity, particularly in the preterm infants. In neonates, the balance of the potential adverse effects from hyperoxia and hypoxia should be considered, and this is a topic that requires further research and study. Pre-medication before tracheal intubation reduces pain, discomfort, and trauma to the airway, obtains physiologic response associated with intubation and laryngoscopy, improves intubation conditions, and decreases the time and number of attempts to successful intubations in neonates and children. Although the use of pre-medication is on the rise, it is still not the standard of care in many neonatal intensive care units. Many neonatologists hesitate to use pre-medication during intubation of preterm infants. Reasons for this hesitation may include fear of adverse effects on the infant's hemodynamic status or neurodevelopment, and unfamiliarity with drugs. Sick neonates also lack physiological reserve to tolerate pre-medication. These patients may benefit from topical lidocaine applied at the laryngeal inlet to reduce airway reflexes, thereby shortening neonatal intubation time without affecting blood pressure, heart rate, and oxygen saturation. Advisory from the British Association Perinatal Medicine for Difficult Airway in Neonates also recommends having institutional guidelines regarding pre-medication for intubation to ensure resource availability and familiarity. In the use of muscle relaxants, one must be cognizant that muscle relaxants may unmask an unexpected difficult airway situation in patients with critical tracheal stenosis or atresia, where ventilation may be maintained through spontaneous ventilation of an esophageal fistula. Use of short-acting, easily reversed drugs should then be the key consideration in our choice of pre-medication. Airway adjuncts help clinicians manage the airway when tracheal intubation has not been successful. Stylets and bougies are simple to use airway adjuncts that aid intubation. The neonatal airway, being soft and small, is prone to injury associated with their use. Beyond simple airway adjuncts, effective troubleshooting of difficult airway management currently relies on good knowledge and skill to use the various advanced airway devices now made available in smaller sizes to cater to the young child. Despite advances in technology, securing the neonatal airway continue to be a problem. Video laryngoscopy may not be as effective in small children as in older children or adults, probably due to the inappropriate sizing of currently available video laryngoscope blades, leading to inconsistencies in exposing the glottis in very small children. Additionally, tracheal tube delivery may also be difficult despite an adequate view of the glottis. Video laryngoscopes generally require a sufficiently large mouth opening and oral space to insert the blade, leaving little room to maneuver the endotracheal tube. Similar problems exist with fiber optic bronchoscopy in neonates. Fiber optic bronchoscopes with a small external diameter may not be readily available. If both tracheal intubation and ventilation via a face mask and superior and supraglottic airway device have failed, invasive front of neck access is indicated as the last resort. Establishing a front of neck access in infants less than 2 kilos or less than 36 weeks post-menstrual age can be difficult due to the neonatal airway anatomy, notably the short neck and relatively thick anterior neck tissues. If under general anesthesia, surgical airways can be established in neonates weighing less than 2 kilograms. Neck anatomy in adults and older children permits needle cricothyroidotomy as a potential rescue technique in a can't intubate, can't oxygenate scenario, and is recommended in the absence of an ENT specialist, even though the technique has high failure rates. In neonates, cricothyroidotomy by scalpel or needle is not possible because it can be difficult to locate the cricothyroid membrane, which is small, frequently less than 3 mm in size. Therefore, front of neck access is not recommended for the management of a difficult neonatal airway in centers without ENT services. Thus, we can only hope to avoid a can't intubate, can't oxygenate situation in a neonate by exercising good basic airway skills and making careful airway management decisions. Before I wrap up, let me take a moment now to share with you the story of baby A. He was born prematurely at 31 weeks of gestation. His antenatal history was unclear, except that he was not normal. The neonatal team who attended to the child activated an airway code after 2 failed intubation attempts. Anesthesia attempted tracheal intubation using smaller endotracheal tubes via video laryngoscopy and concurred with the grade 3 laryngeal view. Glottis was visualized, but the size 2.5 endotracheal tube could not be advanced, and no stylet was available to fit the size 2.0 uncuffed endotracheal tube. In between intubation attempts, oxygen saturation was easily managed with mask ventilation. The neonatal team was not comfortable with the suggestion to use muscle relaxants for intubation. After some time, decision was made to transfer to the operating theatre for intubation by the ENT surgeon via rigid scope or tracheostomy. At that moment, the neonatal team had voiced some concerns regarding surgical airway as the child had features of trisomy, although the diagnosis could not be confirmed. Intubation attempts by ENT specialists via rigid telescopes were not successful, and the child's condition deteriorated quickly with desaturation and hemodynamic instability. The surgeon swiftly performed tracheostomy. Unfortunately, the child suffered bilateral hemothoracis and succumbed soon after in the neonatal ICU. This story reiterates the complexities and dilemmas of managing the fragile and delicate neonatal airway. Unlike in the older children, the chance of successful intubation of the unexpected difficult airway in very small children is quite low with direct laryngoscopy. Therefore, when tracheal intubation is unexpectedly difficult, we should try to maintain a clear airway without repeating attempts at intubation and call for expert help early. In conclusion, I must again emphasize that the size, weight, anatomy, and physiology of the neonate vary greatly from the older child and adult. The neonatal airway is precarious. Failure to modify airway management appropriate to the age of the child can easily lead to complications such as loss of the airway and failed ventilation. It is obvious that airway management protocols in neonates are still not optimal. There remains many uncertainties, and hopefully future research can provide more information on means to improve physiological stability during intubation for neonates and develop innovative tools to make intubation easier in neonates. In the meantime, safe airway management in neonates will hinge on continuing education, skill training, and resource provision. Thank you for your attention.
Thank you, Dr. Josephine. Very nice presentation about the neonatal airway management. It reminds us that children are not small adults, and neonatal have a difficult airway. For me, or neonates are difficult airway. And why they are difficult? Because they are easy to desaturate and having a bradycardia. And also in anatomical position, it's a little different than adults. And also some equipment not all suitable for neonates. You have some cases that remind us how difficult to manage a neonatal airway. We have some question and Q&A, but you can pick the question which are you going to answer through Q&A or live answer after the discussion session. For the audience, if you have cases you would like to discuss with Dr. Josephine or any question, you could write at the Q&A. Later, at the time of discussion, we will answer the question. Thank you, Dr. Josephine. So we will move on to the next speakers, Dr. Akihiro. Akihiro Suzuki is a professor at the Department of Anesthesiology, GC Medical University Hospital at Tochigi. He is an expert in airway management. He has also done some invention, some device for airway management, some forceps for airway management. But today he's going to talk about the ultrasound for the airway management evaluation. Dr. Akihiro, the time is also about 30 minutes. You can start to speak about the ultrasound evaluation. Please, Dr. Akihiro.
Thank you very much, Dr. Sugiarto. Hi, hello, good morning. I'm Akihiro Suzuki from Japan. Today, I'm going to talk about the airway ultrasound. So let's share the slide. Can you see the slide?
Yes.
Okay, and can you see the cursor moving?
Yes.
Yes.
Okay, thank you. Today's my topic is perioperative evaluation of the airway via sonography, the PEACE exam. I am now currently working at GC Medical University Hospital. We have 1,100 beds and 9,000 surgery per year, including 7,000 general anesthesia case. We also do liver and kidney transplantation. Our hospital is 100 kilometers north from Tokyo. And we have World Heritage Shrine, which is another 1 hour drive from our hospital. I am an anesthesiologist, but was an emergency physician and intensivist in the past. Part of my emergency department job was pre-hospital emergency medical service using helicopter or the jet aircraft. During this activity, no CT and X-rays are available in the scene. Therefore, I perform point-of-care ultrasound because it is useful in pre-hospital setting, and it is non-invasive and quick and repeatable. And upon this activity, I have published many books in Japan and China. And now I am a president of Japan ABCD Sonography Association. And we conduct point-of-care ultrasound workshops nationwidely, such as airway workshop, lung workshop, and circulation workshops. The concept of ABCD sonography is to evaluate airway, breathing, circulation, and dysfunction of central nervous system DVTs with ultrasound and provide education. Now let's start talking about the role of ultrasound in the airway management. And I introduce PEACE exam. PEACE stands for perioperative evaluation of the airway via sonography. PEACE is exam, not a protocol. So you can use ultrasound as you like. In many situations listed this. So I will explain about this one by one. As you know, there are 4 elements in the airway management: mask, tracheal tube, supraglottic airway, and surgical airway. First, start from the mask ventilation. We can detect gas insufflation using ultrasound. If the mask ventilation is bad, it can cause gastric insufflation, which may result in regurgitation. And insufflated gas may impede surgical procedure because there are many surgeries done with the laparoscopic approach. And Dr. Bouvet examined whether ultrasound can detect gastric insufflation. They compared ultrasound and oscillation during mask induction. And here's the anatomy. This is cephalad direction, and you can see the liver and stomach and intestine, vessels, and spine. And here's the ultrasound image. You can see liver here, and this area is gastric antrum. This is the point of interest for us. You can also see thoracic esophagus here. And this is cephalad direction, and this is caudate direction. And here's the ultrasound findings. If the stomach is empty, we can see anterior and posterior wall of stomach. And this is the gastric antrum. However, once the gas was insufflated into the stomach gets bigger, and inside it shows speckled pattern. So this sign indicates gas was insufflated. And at that time, they conclude ultrasound can detect gas entry from lower peak inspiratory pressure. It's about 10 centimeter water. On the other hand, oscillation can detect the gas inflation from 15 centimeter water. So they conclude ultrasound is better. Okay, next topic is assessment of gastric contents. We use same view. We observe gastric antrum to check the stomach condition. We can qualitatively assess gastric contents. If there is a clear liquid like water, we can see the echo-free space inside the stomach. And if we eat solid meal, the ultrasound image shows it's like a speckled pattern. And if the patient is full stomach condition, it looks like this. It's like gas or foggy image. We cannot see anything. And here is one example. Here is a 3-month boy who has pyrolic stenosis. He has fasted more than 8 hours, but before induction of anesthesia, his stomach was full. There is a reverbation artifact here. So we put the patient in right lateral decubitus position to observe gastric content. Then the ultrasound revealed there is something, water and other things inside the stomach. So we decided to insert the gastric tube inside the stomach and evacuate the contents. And this is after evacuation. Now the stomach was getting empty. And we were able to induce anesthesia safely under mask induction. We can also quantitatively assess the gastric content. We can measure or expect the volume when using Payless's formula. The formula is like this, and we can determine if the volume itself was 1.5 milliliter per kilogram, then it can be judged as focused full stomach, the risk of regurgitation and aspiration. Okay, next, let's move to the next topic, tracheal intubation. If the patient is full stomach, either awake or rapid sequence induction can be a choice. Now, due to COVID-19 pandemic, many intubation guidelines suggest rapid sequence induction using video laryngoscope. And at that time, we may apply cricoid pressure or Selleck's maneuver. Because with this maneuver, we can compress esophagus to prevent regurgitation. However, effective cricoid pressure is recently questioned. If we apply the pressure, then esophagus moves to the left in 90% of the patient. But now we can see the esophagus using ultrasound. Then we can compress the esophagus by ultrasound probe to prevent regurgitation. Here's the ultrasound settings. We use linear probe with high frequency. And preset should be thyroid or soft tissue, with the gain increased. And this is the transverse neck scan at the suprasternal notch. You can see this is the left side of the patient, and you can see the trachea here, and esophagus here, and this is carotid artery. And Dr. Andrew Kiewicz compared the cricoid pressure and paralaryngeal pressure using ultrasound probe. And they measure the distance from anterior to posterior wall of the esophagus. And at that time, with the paralaryngeal pressure, we can compress the esophagus more when compared to cricoid pressure. Therefore, they concluded paralaryngeal pressure is more effective to compress esophagus. Okay, next topic. Confirm tube position. Esophageal intubation can be fatal if overlooked. And auscultation is a method to confirm correct tube position. However, auscultation is unreliable. This data shows if the practitioner is inexperienced, wrong diagnosis rate is as high as 30%. It's really high. On the other hand, capnography is reliable, regardless of the experience. That's the reason resuscitation guidelines recommend use of capnography to confirm tube position. However, we have capnography in most of the operating room or theater, but most wards do not have. So from 2015, resuscitation guidelines suggest if continuous waveform capnometry is not available, then ultrasound used by an experienced operator is a reasonable alternative. And this technique is particularly useful for medical emergency team or rapid response SIM activity. And here's the ultrasound view. This is a transverse view as suprasternal notch, which I explained before. Now the tube was inserted. This is trachea, and there is something inside the trachea and moving. And during that time, esophagus is remain unchanged. So this is a sign of correct tube placement. And when we insert the cuff, then we can sometimes see the trachea will get bigger, like this. Inflate the cuff, then it expands. Inflate the cuff, it expands like this. This is also the sign of correct positioning. And if you in doubt, then you can twist the tube like this. Then upon this movement, trachea moves. And during that time, esophagus is remain unchanged. Then you can confirm tube is in the correct position. And here's the example of esophageal intubation. Tracheal is here, and esophagus is here. And one of the residents tried to intubate. Then, as you can see, there is a black shadow inside the esophagus. So this is the sign of wrong placement. Tube is going into the esophagus. And after the procedure, if you see this kind of image, you have to remove the tube quickly. This is the trachea, and this part should be esophagus, but it looks like a trachea. So this is called double trachea sign. Or you can see the line here. There are the two lines. This is called double tract sign. So these are the sign of misplacement. And the meta-analysis result shows esophageal intubation, when used ultrasound, the sensitivity and specificity is very high, more than 90%. So in this review, they conclude this technique is useful when capnography monitor value is too low to judge, such as cardiopulmonary arrest or pulmonary embolism. Okay, next topic, let's rule out bronchial intubation. If you want to rule out the bronchial intubation, lung ultrasound is useful. When we put the transducer on the lateral chest wall, you can see the thorax and abdomen simultaneously. And lung expands upon ventilation. Inspire and exhale. Inhale and exhale. So the lung pushes the abdominal organ like this. So this is the sign of ventilation. On the other hand, if the lung is not ventilated, it looks like this. This is not a still image, but it's also like this. This is thorax, the lung, and this is the abdominal organ. There's no movement of the lung. So if you see this image, you can think there may be a esophageal intubation or bronchial intubation. And these techniques can be also used for one lung ventilation to confirm non-ventilated lung. Okay, next topic is surgical airway access. Let's find cricothyroid membrane and other structure using ultrasound. Cannot intubate, cannot oxygenate is an emergency situation for us. And during that time, we have to perform cricothyroidotomy as an emergency airway access. And this is the place to be cut or insert the cannula. It should be in between thyroid cartilage and cricoid cartilage. This is cricothyroid membrane. And all guidelines suggest surgical airway. should CICO happen. However, chance of this kind of emergency situation is extremely rare. According to the Dr. Ketapar's meta-analysis, there was only one emergency case per 50,000 cases. So this kind of emergency access, the technique itself is very difficult to learn and also very difficult to perform. However, there is someone unlucky to draw this bad luck. And we must find the cricoid membrane immediately using surface landmark technique. However, as you know, surface palpation is unreliable even in non-emergent situations. Dr. Elliott recruited 18 anesthesiologists and let them palpate the neck and draw the symbol on the access site, like this. And here's the result. The person who were able to mark inside the cricoid membrane area was 30%, and person who were able to mark center of the cricoid membrane was only 10%. So the success rate may be smaller than this. 30% success rate is good for baseball player, but not good for us physician. But now we can visualize the airway using the ultrasound. So let's take a look. And here's the airway anatomy. This is thyroid cartilage and cricoid cartilage. We see the thyroid gland and trachea here, and this is the hyoid bone. And inside the thyroid cartilage, we can see the vocal cord. We can visualize these structures using ultrasound. And cricoid membrane is important for emergency airway access, which is in between thyroid and cricoid. And in between cricoid cartilage and first trachea ring is important place for retrograde intubation. This is retrograde intubation. Poke the needle and insert the guide wire and thread the tube into the trachea. And trachea ring number 1 and 2, and second and third. This part is important for percutaneous dilational tracheostomy. And now, Australia, New Zealand, and Danish guidelines recommend use of ultrasound during percutaneous dilational tracheostomy. Okay, this is the ultrasound image, the longitudinal view. This is cephalad direction, and this is coded direction. With this image, you can see the very big oval structure, hypoechoic structure. This is the cricoid. This should be the landmark. If you find this, the rest is easy to find. This white line is air mucosa interface. And you can see small oval structure like this. These are trachea rings, first, second, and third. And here you can see the part of thyroid cartilage. Then you can easily recognize cricoid membrane is here. This is the place should be cut or insert the cannula. And you can use this image for emergency access. I call this cricoid cliff technique. If the transducer was put the edge of the cricoid cartilage, you can poke the needle here. Then this part should be cricoid membrane. We use this technique is for topicalizing airway mucosa for awake intubation. Like this. We put that probe and poke the needle. Like this. The probe should be set at the edge of the cricoid cartilage. Okay, next, I'm going to talk about the transverse view to identify airway structure. Thyroid cartilage can be observed as a triangular shape. And you can see the vocal cord here. And this is the cricothyroid membrane. No hypoechoic structures exist, but only a white, bright arc like this. This is the cricothyroid membrane. And it is very easy to recognize and distinguish cricoid and tracheal ring, because cricoid ring is like thick horseshoe like this, which is much thicker than regular tracheal ring. The tracheal ring is very thin. It is very easy to recognize, distinguish these two. And Dr. Christensen in Denmark recommend to use Taka technique to identify air mucosal interface, the cricothyroid membrane. First, visualize the thyroid cartilage and move toward the caudal direction to visualize air mucosal interface. This is cricothyroid membrane. And move more to visualize cricoid membrane. And then return to the cricothyroid membrane. So thyroid, air, crico, and air. So this is the reason they call this Taka technique. And I also propose we should perform ultrasound-guided cannula cricothyroidotomy in 2012. But skill maintenance is important to lower the threshold for surgical airway access at the emergency situation. And this is the patient who has a mandibular fracture and requires a nasal intubation. In such case, we use ultrasound-guided topicalization of the airway. So we use a very small bore cannula like this and inject the local anesthetics from here before awake intubation. And here's the ultrasound image. Now we visualize the cricoid cartilage and needle will start advancing. And this line is cricothyroid membrane. Now the needle is around here and advance the needle, advancing the needle a little bit more. And now we felt the pop. And then we were able to access the airway like this. And the latest DAS guideline, 2015, recommends the role of the ultrasound. The ultrasound can detect the anatomy even if palpation fails. So ultrasound is necessary skill and requires training. And here's some example. This is a neck abscess case in obese patient. The neck looks edematous. When we look at the neck, it's like a cobblestone appearance like this. It's swollen and it has a wetty situation. But we were able to identify cricothyroid membrane like this, and we discussed with ENT surgeon whether we should induce the anesthesia first or the ENT surgeon perform the tracheostomy first. We can use this technique like this. Okay, additional information. We can assess neck anatomy. This is the video clip of vocal cord assessment. The patient complained about the hoarseness, but when we watch the vocal cord, it moves bilaterally. So it indicates there is no vocal cord paralysis or paralysis, even if patient complained hoarseness. And this is the airway trauma case. The male patient who had a motorcycle accident and complained throat pain. And at that time, we found his thyroid cartilage was fractured like this. So if this situation is unrecognized, intubation may compromise the vocal cord function. So this examination is important, I think. And here's the swollen mucosa due to airway burn. The airway mucosa gets thicker, which is identical to the CAT scan image. Maybe this patient is difficult to extubate because of the airway obstruction. And here's another example. Thyroid gland tumor, big one. This is the CT image and X-rays 2 weeks before surgery. Even at that time, trachea gets narrower and trachea gets narrower. And ultrasound gives us the latest information just before induction or the day before surgery. His trachea gets narrower and narrower. When we measure the distance between here, then we can choose the best side of the tube. Okay, I introduced about the PICS exam. I talked about the stomach thing and tracheal tube conformation and cricoid membrane and other structures and etc. Thank you for listening.
Thank you, Professor Akihiro. That's a quite interesting exam that you propose, PICS exam. It's an exam, not a protocol, but I see a lot of uses. We can use the examination. You can look at the esophagus with ultrasound, so you know where to do the pressure, also confirmation of the tube position, and also confirmation of the cricothyroid membrane. We see a lot of new uses of ultrasound thanks to your explanation. We have some question for Professor Akihiro, but you can answer later at our discussion sessions. We move on to the next speaker, Professor Andrei Van Zunder. He is a professor in University of Women and Children Hospital in Queensland, if I'm not mistaken. He's an expert in airway management. We have him talk several sessions in airway management before. He's going to do introduction of the new videolaryngeal mask airway. Is it a future or any prospect of videolaryngeal laryngeal mask airway? So we asked for Professor Van Zunder to start his presentation. Please, Professor Andrei, the time is yours.
Thank you, Adri. Thank you for the introduction. Ladies and gentlemen, I'm very pleased to give a presentation here on videolaryngoscopy. I hope the slides can be seen by everybody. Is that correct?
Yeah.
Okay, let me just put this on the side. Yeah. Okay, good. Okay, videolaryngoscopy with the new supraglottic airway devices. Yeah, it has been the topic for me already for the last 15 years. Now, first of all, I would like to say Brisbane, that's a city where I live nowadays in Australia. It's the capital city of Queensland, and that's also the host city of the 2032 Olympics and Paralympics. So welcome. I usually would like to say nice things about Brisbane, but just last weekend, and we had an enormous flooding of the area. This is the where you can see the city center here, and I'm living just over there. And you see the enormous flooding we had, and unfortunately, it has cost 11 people their lives. And you see the devastating images here with lots of debris and billions of dollars of costs involved. as you can see here, many boats sinking. Yeah, but anyway, I'm from the University of Queensland. This is one of the top 50 universities in the world, and I'm going to talk about the third generation supraglottic airway devices facilitating direct vision placement. Yeah, so for years I was thinking about video laryngoscopy guided insertion of supraglottic airway devices, and I thought we need to do something better, and that's what I'm going to talk about today. So I'm going to talk about two new devices here, the video laryngeal mask airway and the safe laryngeal mask airway, two devices which are available. And just recently I found out there's even a third one, but I don't have the information as yet. So we just published a few months ago features of the new vision incorporated third generation video laryngeal mask airway. And please have a look at this in the Journal of Clinical Monitoring and Computing. So is this vision guided insertion of supraglottic airway devices the final solution to avoid malpositioning? Because that is the problem. Yeah, malpositioning. We want to have good views of our glottis. Yeah, and that's not always available with blind insertion technique. So I'm going to talk about two of these video laryngeal masks which are available on the market as yet. The E-scope video laryngeal mask and the safe video laryngeal mask. And why is that necessary? How do I know that the device sits appropriately, sits correctly? Thus far, with the blind insertion technique, the gold standard is the use of the oropharyngeal leak pressure, which for first generation is about 20 centimeters of water. For second generation, it's about 25 centimeters of water. And then you have the fiber optic evaluation, yeah, and you see good views or less than optimal views with a fiber optic scope, yeah. But that does not allow you to do any corrections of any of the malpositioning. So that is good. It's expensive, but it does not allow you to do any correction of the insertion. Now, so what is the value of the oropharyngeal leak pressure and intracuff pressure if one does not know the exact position? So I question many publications if they do not guarantee that the position is correctly. Time to consider supraglottic airway device oropharyngeal leak pressure measurements more objectively. We just published an article in Acta Scandinavica last year on this topic, and I would advise you to read this article because it gives you a lot of information about oropharyngeal leak pressure. Now, the blind insertion technique usually results in malpositioning of the device in 50 to 80% of the time. That means I call that failed supraglottic airway device. Yeah? It has been proven over and over by imaging techniques, MRI, CT scan, radiology, ultrasound, clinical research, and fiber optic observation. Nowhere in medicine this high rate would have been acceptable by other disciplines in medicine. And no anesthetist would accept a tracheal tube insertion that resulted in a leak with ventilation. So are we using different standards here? With the vision-guided insertion technique, and that's based on what we described as the insert, detect, correct as you go technique, malpositioning is virtually eliminated. So instead of 50 to 80% of malpositioning, I can reduce that to less than 5%. So 95% or more correct positioning. And for that reason, I think we need to see this lecture. The vision-guided insertion technique is better because what we see, we can do better. So we need to visualize what we are doing in airway management. Now, these are a few images here which I want to show you during the insertion process of an LMA or a supraglottic airway device. Yeah, that is what you normally do. And have a look, please, at this image. Yeah, the artist who was drawing all these things did not know what to do. And I'm just going back one slide. You see here the epiglottis, but then all of a sudden the epiglottic, where is it? Is it on the right side of the device? Is it in the device? Is it on top of the device? I don't know. Yeah? But the good thing is the tip of the device sits correctly into the entrance of the esophagus. And once inflated, you have a good seal, yeah, sealing off the glottic entrance so that there's an airway exchange possible between the trachea and the lungs and the outside situation, with the tip of the cuff inflated into the entrance of the esophagus. That is what we want to do. But that's blind insertion. You're never sure whether that actually will be realized. You see a sagittal view here. That is the air coming in, yeah, in the trachea, and it goes out here as well. But it's not always the case, because you see the epiglottis is here positioned outside the device, and that is how it should be. But here it is inside the device, and exactly you see it here. The epiglottis is sitting in the bowel of the device, creating leakage and sometimes even obstruction. That is not what we want. And Shandy Verghese give us some maneuvers to compensate for any incorrect positioning. There's also a non-exhaustive list of subjective verification of whether the device sits accurately. You please read this in the Journal of Clinical Monitoring and Computing last year. Yeah, you see that here, the case for a third generation supraglottic airway device facilitating direct vision placement. All these subjective methods, well, they try to help us to find out whether the device sits correctly, but that's not the case. Yeah, and none of these tests really prove that the device sits correctly. It's not 100% proof. It helps, but it's not 100%. So what we want to have a first seal, the blue one here, yeah, with an inflated cuff. Seal entrance is completely sealed off from the rest of the oropharynx and the trachea, and the tip of the cuff should seal off the entrance to the esophagus. That is what we want to do in order to prevent aspiration. So an optimal fit for supraglottic airway devices leads to better function. From an anatomical perspective, the tip of the distal cuff should sit, yeah, and blocking the upper esophageal sphincter, and the distal cuff should sit and occupies the hypopharynx. So we have a first and a second seal. And the epiglottis should be flattened, yeah, as you can see here, between the inflated cuff and the base of the tongue. From a functional perspective, there should be a functional barrier, adequate gas exchange, and no trauma to the airway. And that should be realized. You see here, perfect alignment of the tip of the epiglottis and the proximal cuff of the device here. So that tells us this is the right size that we are using, okay, in 3 of these examples here. But sometimes the first seal is not obtained. And I give you 2 examples. This is the eye gel. The eye gel has no inflatable cuff. So sometimes you see a gap here. A gap means air leakage. Air leakage means that you and all the others of the team, yeah, in the operating theaters are breathing in also the gases, yeah, that are delivered to the patient. This is another example where PVC cuffs, for instance, of the LMA Supreme, yeah, are not completely inflated, yeah, completely deflated, creating gaps here. Again, the same problem. Gaps means air leakage and potential inhalation of gases by the team as well. Now look what is happening here. We have here the mouth opening, the oropharynx, and this is the nasopharynx. Yeah? A major obstruction, in fact, is the tongue. In order to insert any device that goes in and opens the airway, yeah, it needs to go around of the tongue. And then we have the epiglottis. The epiglottis sits, yeah, in fact, facing the posterior pharyngeal wall here. Okay, so anything that comes in here is automatically blocked by the epiglottis, unless we bring the whole mandibula forward by lifting the jaw. okay, then we increase the space from the posterior of the tongue till the posterior pharyngeal wall. This distance should be increased in order to insert any device here, whether it's an LMA, a supraglottic airway device, or a tracheal tube, or any other adjunct. This is a patient lying on in the supine position, breathing, as you can see here, breathing to the nose, breathing to the oropharynx. And there's a clear distance between the posterior part of the tongue and the posterior pharyngeal wall. This allows us to breathe in and out unobstructed. But look at the next one. This is a patient who is comatose. During the administration of anesthetics, the patient stopped breathing. No more air exchange here. So, and what happens next is that the tongue falls backwards, obstructing the airway. There's a complete obstruction, then you don't hear anything. If there's a partial obstruction, then you hear snoring. Okay, so what you need to do is lift the jaw in order to create space behind the tongue. That is what we want to do. So if we do a blind insertion, we still have to make sure that the device goes at the very back of the oropharynx. Now, look what can happen. Yeah, an ideal size for the patient is when the tip of the epiglottis is aligned with the rim of the proximal cuff. So that should be aligned. If this comes lower, yeah, like in this situation, that means that either the device is too small, the cuff is inflated too much, or the device sits too superficial. Or the reverse, the device sits too deep, the device is too small, or the cuff is not inflated enough. Please have a look at this publication. We published in 2016 in the British Journal of Anesthesia, Malpositioning of Supraglottic Airway Devices, Preventive and Corrective Strategy. The editor-in-chief considered this as a very important editorial, and even put our article on the cover of the journal. And here I'll show you a few of these malpositioning. You see here the epiglottis facing backwards. Yeah, anything that you put in down here will result in downfolding. And exactly that's happening here. Downfolding of the epiglottis occurs in 80% of all the cases. Yeah, but look here. This is what needs to be done. Yeah, the correct size should be aligned, as you can see here. It should not sit too deep. If it sits too deep, you see here, there's no alignment anymore. If it sits superficial, again, there's no alignment anymore. And that risk, the risk here is dislocation of the device. During maintenance of anesthesia, all of a sudden you can lose your airway because the device is now dislocated from its position. And another thing is that the epiglottis sits in the device itself, creating air leakage and sometimes even complete blockage as shown in here. So we need to be careful. Visualizing the technique, make sure that we see that the device is from the correct size and sits correctly. I've explained to you that there is a possibility of air leakage due to the lack of an inflatable cuff. Yeah. This is a silicone device. The cuff is made from silicone, thus which results in a nicely deployment of the device, whereas PVC not always results in the same deployment, and that can be a cause of air leakage. Here the tip is folded backwards here. It does not sit into the esophagus. There's no clear second seal, and that can result in aspiration of stomach content. And here the distal cuff of the device sits between and across the vocal cords in here, creating a massive leak, and again, that can result in aspiration. This is the epiglottic downfolding that occurs quite often, or even the sideways. So the epiglottis is now folded double in here. Whereas with fiber optic evaluation, we want to see the full POGO, from a percentage of glottis opening in this particular area is 100%, 100%, 100%, and as you can see in here. Yeah? Whereas this is not so good because the epiglottis sits now in the bowel of the device, partially obstructing, and it even can cause complete obstruction. And the mask aperture bars were designed to prevent epiglottic downfolding, but we have proven in other publications that the mask aperture bar have no meaning whatsoever, so they should not be included as in this particular case. So air leak can be the result, as you can see here, or complete obstruction, as in this particular case here. Yeah. So we need to do something better. Fiber optic evaluation. Sorry, I'm going backwards. Yeah. So and even this obstruction can be significant, even with this mask aperture bar, and sometimes they are traumatizing the airway or the epiglottis, as you can see here. And sometimes you have a complete obstruction. Yeah, and during maintenance of anesthesia, that is not a good situation. So look at the British Journal of Anesthesia, where you can find all the description of these cases. It is not only in, it happens with all the devices, not only with certain devices, it happens with all LMAs, all supraglottic airway devices, all the brands. Correct insertion means that you have to lift, in fact, the jaw. A jaw lip is essential, jaw thrust, insert the device, make sure that it sits in the entrance of the esophagus, and then you can seal off with an inflatable cuff the trachea inlet. Yeah? Epiglottic, the distal cuff can be folding backwards. That's not what is essential. You see here the distal tip sitting in between the vocal cords in 4 cases here. We have described too deep, yeah, as you can see here. So the size is not the correct size here. Yeah? Laryngeal masks are very forgiving devices, but the calamity can be dislocation, malalignment. As you can see here, the device is too big. The airway tube and the glottic entrance malalignment, air leak and obstruction can result, and that promotes epiglottic positioning in the bowel device and gas exchange impairment on obstruction. That's not what we want. Epiglottics folding double, you really need to correct this, otherwise you will have obstruction of the airway. Folding, you see with the silicones ones, that is in the correct position. With PVC ones, you see several of these devices were creating leakage. So we came to a grading system. We published that in an editorial in the British Journal in 2017, the failed supraglottic airway device, an algorithm for suboptimally placed supraglottic airway devices based on video laryngoscopy. So we were using, in those days, video laryngoscopes to insert a supraglottic airway device. And we graded it as 1, 2, and 3. Grade 1 is this position here, a perfectly seated supraglottic airway devices, demonstrating the exact size, epiglottic resting on the outside of the device, producing a normal capnogram, good air entry, excellent gas exchange, and an oropharyngeal leak pressure 25 centimeters or more, intracuff pressure normal, and saturation well above 95%. So proceed with anesthesia and surgery, no problems to be expected. Grade 2, these are marginally positioned supraglottic airway devices, as this situation here. Adjusting maneuvers or a change of a size or brand are needed, because you will have airway leaks, abnormal capnograms, impaired gas exchange, and the values are lower for oropharyngeal leak pressure, cuff pressure, and saturation. But it's still possible. Laryngeal masks are very forgiving devices, and it's still possible to provide anesthesia, and you can go away with it. But you cannot continue with a grade 3. Grade 3 is where the distal cuff sits between the vocal cords or provides results in an obstruction. These are clinically unacceptable situations with severe gas leak, airway obstruction, inadequate ventilation, and very low values of leak pressure, intracuff pressure, and low saturation. You need to change that or change your technique. We described what to do, and I'm not going to do that given the time frame here, but this is the optimal position. These are the positions, incorrect malpositions, and how to do the correction. Please read it in the article. Yeah, failed supraglottic airway devices, an algorithm how to change from suboptimal to optimal place supraglottic airway devices. And we did a prospective audit on about 400 patients, and exactly demonstrates what I described before. So a good seal, that is what you need, no leakage, as in these cases. So laryngeal mask airways, the insertion process certainly is important. And for me, the ideal features would be a second generation supraglottic airway devices, optimally positioned, yeah, using a video scope. And that's where I'm going to talk in a second about. With supraglottic airway devices also can serve as an intubation conduit to insert a tracheal tube. Secondary comes to be the sizes of the device, the cuff pressures, and the oropharyngeal leak pressure. No longer the gold standard. We did a prospective study comparing the airway seal using two devices, the LMA Supreme and the LMA Protector, as you can see in here, with the insertion using a video laryngoscope to make sure that the insertion was correctly. You know, the blind insertion technique results in 50 to 80% of malposition. With the vision-guided insertion technique using video laryngoscopy, the correct insertion was 96 to 94%. So very high success rate. So why going blind if you can see? So supraglottic airway devices insertions and malposition, it can all be corrected. But I'm also using a vision-guided technique using video laryngoscopy to insert my nasogastric tube, orogastric tube, temperature tube, because I absolutely want to be sure where is my device going. Yeah, with an endotracheal tube, you know exactly how deep it will go into the trachea, and you even can use it to position the NIM tubes in thyroid surgery. But clinicians still rely entirely on the subjective indirect assessment to estimate correct placement during blind insertion. For that reason, we need the third generation supraglottic airway devices equipped with cameras and fiber optic illumination to optimize the position. Yeah? And that is what we discussed in this article. So we were comparing two new devices, the video laryngeal mask and the safe laryngeal mask. The video laryngeal mask is produced in China by this company here, and the other device is also produced in China by this company, okay? And we showed the characteristics, the features of the new devices incorporating a second generation device, which we call now a third generation laryngeal mask, because it incorporates a video scope. We compared, and again, please read our article here because it's far too extensive, but we compared all the characteristics, the similarities and the dissimilarities of the two devices here. And please read it in detail. Yeah. So the video laryngeal mask comes with a second generation device in which you insert a video scope in a separate blind-ended channel, as you can see in here. Yeah? And there's a camera here, a camera that gives you the vision of what happens here in front of the vocal cords. So you see here all the different characteristics here, but basically it is a camera here, yeah, in a remote area, so you can put it somewhere near the head of the patient where you easily can visualize it, and the rest of the team can see it as well. Yeah, you see the vocal cords, you see the arytenoids, you see the device sitting correctly here. Yeah, and that is all possible thanks to the insertion of the videoscope into that channel, a blind-ended channel, so there's no contact between the videoscope and the contents of the oropharynx. Oops, it's going too fast now. All of a sudden, I don't know why, but anyway, yeah. So you see several of these situations. Now, just to give you an idea how simple it is and how little time yeah. You see the insertion here, and look at the camera at the screen, the monitor screen, and you will see the vocal cords sitting there. Yeah, you inflate the cuff. Yeah, and in fact, this is you see the pogo here. It's 90%. And in fact, you can use it as an extra monitoring during the whole maintenance of anesthesia. Yeah? Okay, so you can see clearly the entrance to the trachea here. It is, you can realize a safe airway within a few seconds here in all these patients, as you can see in here. Yeah, it can be used and published in gynecology. Yeah. Or it was even used for the very difficult intubation with an awake intubation. Yeah. So awake intubation is a possibility. I'm not sure whether that will be feasible in all the patients. Yeah. These are the two devices here. Please read all the different instructions in our article here. But that is what you see. You see the vocal cords completely, and it's easy to insert the tracheal tube via the laryngeal mask. Yeah. You see the camera here. Yeah, it's a blind-ended tube. And in fact, what are the advantages? You see good visualization of the insertion process of the LMA, but also of the tracheal tube, as you can see in here. These are the kind of views that you want to see. Easy positioning of the LMA, adequate and optimal position of the LMA if there's a need to, good visualization of the vocal cords with the pogo, adequate inflation of the cuff is possible, no epiglottic downfolding, use the device as an insertion conduit for the insertion of the gastric tube and the endotracheal tube, and you easily can check with the fiber optic bronchoscope. In fact, there's no need to check it anymore with the fiber optic bronchoscope because you actually can see it. So it saves you money as well. Visualization of the tip LMA, that should sit into the esophagus, and the tip folding over, yeah, this is still something that needs to be solved. Verification of the correct size, I've told you, yeah, the size should sit with an alignment of the tip of the epiglottics and the rim of the proximal cuff. It allows continuous monitoring during the maintenance phase, so you have actually with this device an extra monitoring of the airway, which did not exist thus far. The device allows oxygenation and ventilation during the insertion, and obviously you need to do a cost analysis that enable users to make a balanced decision which device to buy. But these are the kind of images that you want to see. Yeah? And you can use it also for intubation. And we all know that these devices are now an essential device in the difficult airway algorithm. So this is the way forward. This is what I call the third generation supraglottic airway devices with a second generation device to which a videoscope is inserted, as you can see in here. Yeah. In the past, there were two of these devices available, the LMA Fast Track or ILMA, yeah, and the Total Track VLM from Medcom. In fact, these devices were not made to insert the devices, but to insert the tracheal tube, yeah, to visualize the tracheal tube going into the trachea. This one no longer is available. The Medcom Total Track is still available. Yeah? So please read this article, The Case for the Third Generation Supraglottic Airway Devices, yeah, in the Clinical Journal of the Journal of Clinical Monitoring and Computing. I think this is the way forward. We will use these kind of devices much more in the future both to insert safe and correct positioning of supraglottic airway devices and endotracheal tubes. I thank you for your attention. Happy to answer any question.
Thank you, Professor Andrei. Very interesting presentation you have about the videolaryngeal mask. We need videolaryngeal mask to assert that the laryngeal mask that we place is in the good position, that the ventilation is possible without leakage and without trauma to the epiglottis or surrounding structures. If you have time, we will now move to the next session, which is a discussion session. If we plan to do intubation, do you prefer doing it with muscle relaxants or not? No muscle relaxant. If we at first we suggest that this patient is not difficult in anatomical way, do you prefer doing with the muscle relaxant or not?
So it depends on whether you have accessed the airway to be difficult. Muscle relaxants have been associated with a higher success first attempt intubation. So if there is no contraindication, then I would prefer to use a muscle relaxant. If you use just sedation without muscle relaxants, generally you will need more of the sedation drugs, and then that might affect the blood pressure of the patient. So if possible, then if there's no contraindication, I am able to back the patient well, I may use a muscle relaxant.
Okay, thank you, Dr. Joe. We move on to a question for Professor Akihiro. Maybe a little bit concerned about the placement of the ultrasound in obese patient. In any way, do you have done ultrasound evaluation in the neonate or babies? We have the same problem with obese patient because the very short neck, very small spaces. Do you have experience evaluating the ultrasound in the babies or neonates, Professor Akihiro?
Thank you for your question. For baby and neonates, they are very small, so it is very easy for ultrasound to penetrate the tissue. So the view is very good, particularly for vocal cord function. We can easily watch the vocal cord itself and its movement. So the smaller the patient, the easier to visualize the structure. This is my opinion.
Okay, thank you, Professor Akihiro. Dr. Joe, do you have any experience using ultrasound in the small babies or neonates also?
Yes, so definitely I agree with Dr. Akihiro. The younger they are, sorry, I apologize for that. Yes, it's easy to see structures because they're very superficial. The child is very small, except that when they're very small, the features are also very small, and therefore it is still difficult despite the ultrasound, although it is easy to see with the ultrasound. But because to access with the puncture, because the structures are very small, so it is still very delicate.
Okay, thank you. Professor Akihiro, when you're doing the PIS exam, you are training some of your doctors to do the PIS exams. How long does it take for them to, in convenient way, that they are able to do the PIS exam for the patient?
We usually conduct the workshop for 1 hour, for 30 minutes lecture and 30 minutes hands-on. So it's enough to get the basic technique because it is very easy. Only longitudinal and transverse view is required, and participants easily get the visualization technique after the workshop. And then they should start performing for obese patient and other things. But the basic is very easy to learn.
Wow, 1 hour workshop already can explain all the side of this exam. Wow, quite great.
Yes.
Okay. Maybe we should try training some of them here in Indonesia next time. We are doing some ultrasound, but not all. It's an exact exam. So we are trying to do your piece exam so perioperatively, so we can do evaluation of the airway. And do you have any comments or experience about evaluating the airway difficulties using ultrasound, Professor Akihiro?
Please say again your question.
Do you have any experience about evaluating the difficulties of airway through ultrasound, maybe some space distance from the thyromental or some other stuff that we could consider that this patient is quite difficult to ventilate or intubate?
Some of the investigators proposed to predict difficult intubation or difficult laryngoscopy by measuring the thickness of the neck tissue. However, as Dr. Van Zunder told, now we can use the video technology. So for difficult intubation or difficult laryngoscopy, maybe we should choose the video laryngoscopy to intubate the patient. And this is the most easiest way to solve the problem.
Okay, so we move on to Professor Van Zunder. Prof. Andrei Van Zunder, there are questions for you. Do you think it's probable or possible or ideal to use smaller size LMA, size 2.5 for 60 kilogram moment to avoid sore throat? Is it okay to use smaller LMA?
Thank you, Adri, and thank you for the participant who asked this interesting question. For me, you need to use the correct size. As I've demonstrated, only the correct size will prevent any leakage or obstruction. Using a smaller size in order to decrease the number of, to decrease the incidence of sore throat, that's not the way. Sore throat, I think I'm absolutely convinced with my many years of using video laryngoscopy, showing all kinds of malpositioning, that sore throat is due to the fact that the device is sitting incorrectly, that the device is inflated far too much, and that the oropharyngeal leak pressure is not correct. So correct the size, correct the optimal position, and you will see less incidence of sore throat. So no, I would not decrease the size. It's not the size that will result in sore throat. Okay?
Okay, thank you, Professor. Right now we have about 515 audience, quite a lot, and some of them are asking question and question are adding also. For Professor Van Zunder, is there what's your opinion about PEEP usage in LMA ventilation during intraoperative period, especially in practice that insert LMA blindly? Is it safe or contraindicated when you are using PEEP to LMA?
Okay. First of all, I would like to say something about the incidence of the use of supraglottic airway devices, LMAs, in the world. About 2/3 of all general anesthetics in the world are provided with supraglottic airway devices, and only 1/3 is provided with tracheal tubes. So the indications, whereas Archie Brain in the 1980s was very careful and very, well, telling us use it only device in elective surgery. Nowadays, it also can be used in emergency surgery. It can be used in the difficult airway management, and it has a very prominent place. Look at the ASA guidelines. They just appeared a couple of weeks ago of the American Society of Anesthesiology. The device is used whenever there's a difficult airway, so to buy some extra time or to use it as an insertion of the tracheal tube, as a conduit for that. It's also used in emergency cases, in intensive care, and even in obstetrics. Now we see series of publications where they are doing the airway management with LMAs in cesarean section. So the indications are broadening because we do understand more the problem. We understand the device much better. We understand what we can do to manage and avoid complications. So yes, you can use supraglottic airway devices with muscle relaxants. Yeah, although I'm a little bit against that, in the sense that we know allergic reaction and anaphylactic reactions are seen most frequently when you use muscle relaxants. So if there's no need to do that, then there are lots of surgical interventions who do not need muscle relaxation. So if that is the case, don't use it. And if you want to use PEEP, I would say you can do that, but just a little bit of PEEP. 4 or 5, that is safe. Not going up to 50 or 20 centimeters of PEEP. That is not good enough, because you will see that there will be leakage, I guess. I hope I answered that question.
Yeah, thank you, Prof. Van Zunder. Professor Akiro, you are previously, before becoming anesthesiologist, you are an emergency physician. Do you have any experience using LMA in the emergency situation there?
Unfortunately, when I was in emergency department, it was about 2000 year or so. So at that time, there's no data which support the use of LMA to the emergency surgery or emergency situation. Only suggest if in case of cannot intubate and cannot ventilate, then we can try insertion of the LMA. But I never experienced such situation.
Okay, thank you, Professor Akiro. Move on to the next question for Prof. Andrei. This is the situation in Indonesia. Since video LMA is not available in Indonesia yet, is there any tips on how to see the proper position of LMA by using video laryngoscope? Because video laryngoscope is quite common these days. Is there any place to put the blade, or how to view the proper position of the LMA?
Well, what I described today is the 2 new devices, the video laryngeal mask devices. Perhaps that will be the future, and the future will tell us whether this is correct or not. But I was using for 15 years video laryngeal mask, video laryngoscopy to control all aspects of airway management. As I told you, I'm using video laryngoscopy for all my airway management, to insert all devices, supraglottic airway devices, LMAs, tracheal tubes, a nasogastric tube, orogastric tube, a temperature probe, because I really want to be absolutely sure whatever I put into the mouth, that it sits correctly in either the esophagus or ideal-wise for the airway tube into the trachea or around the trachea. That is what I want. Yeah. So you can use a video laryngoscope, but I would suggest use a MAC video laryngoscope. Yeah. Not the acute angle, because the acute angle will give you a different view. So use a MAC blade video laryngoscope. But be aware that the size of the video laryngoscope also needs some extra space into already a crowded oropharynx where there's an airway inserted, and that makes it sometimes complicated. Yeah, so you need to practice on a mannequin first if you want to do that. Now, even Archie Brain saw that there were malpositionings at the early stage in the very first publication in the British Journal of Anesthesia. I think it was 1982. Yeah, where he described, if you are not satisfied with the device, if it is not sitting optimally, yeah, use a laryngoscope. Even a normal laryngoscope will tell you whether the device sits correctly or not. Yeah, so even in the worst case scenario where you don't have a fiber optic scope, where you don't have a video laryngoscope, yeah, you can verify your device using a laryngoscope with direct laryngoscopy. But better is with a video laryngoscope, because a video laryngoscope allows you 60 degrees of the angle of view, whereas a normal classic laryngoscope only allows you 15 degrees, yeah, of view. So the angle of view is very important, and with the classic laryngoscope, it's only 1/4 of what you can see with the video laryngoscope. Is that clear?
Thank you, Professor Van Zunder. So we can view better with the video laryngoscope. Certain video laryngoscope is better than the others to confirm the placement of the LMA.
Can I just add to that? Perhaps if the mouth is crowded, perhaps we could use a slightly smaller blade because it still allows us to have a view, but then at least we can insert, because if you insert appropriately, we are not actually intubating with the video laryngoscope. We just want to have a look at how well the LMA is sighted. So if the mouth is very crowded, perhaps just one size down, then you could then insert it and you could have a better view, rather than maybe if you put a big video laryngoscope blade, you might actually dislodge your already inserted LMA. I'm not sure if that helps.
No, for sure it helps. Yeah, the blade size is less important than the blade itself. So the angulation of the blade should be a Macintosh. Yeah, a Macintosh video laryngoscope. That is what you need, not the angulated ones and not the channeled ones. The channeled video laryngoscopes will not help in this situation. You need the indirect, non-channeled video laryngoscope of a Mac blade. That is what is needed. Yeah. At the same time, and that is something that video laryngoscopes can do, and what is not possible with the video laryngeal mask at this particular moment, is that you actually can verify the size by just checking the tip of the epiglottis should be aligned with the rim of the proximal cuff of the device, and that should be equal. Otherwise, your size is not the correct one.
Okay, thank you from Professor Van Zunder. I have questions for Dr. Joe. Do you prefer intubating using a laryngoscope blade, Miller or Macintosh in the neonates? Because I rarely do intubation in neonates, but when I do intubation in neonates, I usually prefer Macintosh because I use Macintosh a lot than Miller. Would you suggest, Dr. Joe?
I think either type of blade that you use, as long as you can see the glottic view well, then it doesn't really matter. As long as it gets a tube in. But sometimes when the child is very, very small, the width of the mouth is very narrow, and Macintosh blades tend to be wider in size, and therefore might be a little bit more difficult to insert the blade, as well as the sizing itself. In very, very young neonates, like you need to use a size 00 blade, and that's not available in the Macintosh curve blade. So then you actually have no choice but to use a Miller blade. So I think it doesn't really matter in the older infant. If you're familiar with a curved blade and you can see the glottis well and you can pass a tube in, then I'm not here to say that you must use a Miller blade. So that's fine. But in the very, very young, the size of the mouth is a limit. And also the size of the blade. You don't have like a 00 curved blade. So then that limits you and you have to use a Miller blade.
Okay, thank you. Since the time is up, because I already seen Krisa and Dr. Susilo on the view, that means the time is up. Thank you for the presentation and discussion from Dr. Josephine, Professor Akihiro, and Professor Andrei Van Zunder. We have a lot of interesting ideas and concepts to do in our practice daily, especially in airway management. Hopefully with this session, we have a lot of improvement doing our airway management, especially in neonates, adults, and all difficult airway management. So the time is up. Thank you for the audience for the questions and the discussions, and thank you for the speakers to have given us quite a lot of information. So I returns the session to Krisa. Thank you.
Also, thank you, Dr. Adri, for moderating the session very well. Again, thank you so much, Dr. Josephine, Prof. Akihiro, and Prof. Van Zunder for spending your afternoon and morning with us. Thank you very much. Hopefully next year we can be together in Jakarta. Finger crossed, finger crossed. All right, thank you also for Advanced Medicare Corpora for sponsoring this event. Thank you.